Hello, and welcome to week 6 of Assessment and Psychopathology for spring 2025. Again, a few comments to wrap up last week and a few comments for the coming week. I've enjoyed, reading your posts for the discussion for this last week. I thought you all did a really great job, and some of you got really creative with your differential diagnosis, comparing schizophrenia to the other psychotic disorders, and some of you chose disorders outside of that section of the DSM. And I think it's a really important discussion to have, and you all seem to be understanding kind of how different diagnostic categories interact with each other, how these are not really neat, tidy categories, but there's a lot of room for interpretation. And I think it came up in quite a few of your posts that it's not uncommon for somebody to end up with a diagnosis and for that diagnosis to change as more information comes to light, or as a clinician is working with a client longer term and learns more about them, or sees the kind of manifestation or the existence of more symptoms. I can think of several people that I've worked with when I was in community mental health, and even currently, that appear to have a certain diagnostic kind of profile, and then either time passes and new symptoms show up, or we see new symptoms, and so something the person might not have known how to describe or recognized as being significant to the process of assessment shows up, and then that changes the way that we see diagnosis. I think it's especially interesting to note, many of you in this sort of general category talked about the difference between schizophrenia or schizophrenia spectrum and bipolar disorder. Several of you talked about schizoaffective disorder, and there's a lot of overlap there. So very often, especially when we're new to this and we're new to seeing psychosis, I think I talked about this a little bit last week. It is really easy to see psychotic symptoms and delusions, hallucinations, paranoia, and assume schizophrenia, especially if somebody is presenting as confused or their speech is disorganized. But as hopefully you learned this week, and we'll learn more as you get into mood disorders and major depression and bipolar disorder, psychosis can come with those things as well as substance use disorders and other medical conditions. And so it's real easy to jump to schizophrenia. And I mentioned this in one of the posts, but I don't know that you all will see it. 50 years ago in the 60s, 50 to 60 years ago in the 60s and 70s, people were often diagnosed with schizophrenia when their providers or clinicians didn't know what else to label them with, and when they had anything that was confusing or difficult to treat. As a matter of fact, and I'll probably talk about this more when we get to personality disorders, but Marsha Linehan, who is the creator of dialectical behavior therapy, was diagnosed with schizophrenia when she was in an inpatient facility when she was 18, and she was there for 2 years, and she was considered the most difficult client that they had. They didn't know how to treat her. Nothing they knew to do at that time was helping her. And so they gave her that label and kind of said she was beyond their help. And of course, when she, through her brother's advocacy, was released from the institution and went to school herself and learned a lot about healing, she later recognized that borderline personality disorder was a more accurate diagnosis for what she was experiencing. Very little was known about it at the time, and even until the 80s and early 90s, it was kind of considered an untreatable disorder simply because nobody had developed a treatment that worked, which DBT does, and she developed it in part because she understood, the symptoms or the behavioral patterns of somebody with that diagnosis, because that fit her circumstances. And now, borderline personality disorder is considered one of the most treatable disorders there is out there, but it used to be lumped in with schizophrenia. And then in the 70s, when Bessel van der Kolk, if you may be familiar with that name, was working in the VA setting, he's a psychiatrist, also a therapist, he was working mostly with veterans who had come back from Vietnam. And again, when veterans would have flashbacks, and PTSD can come with some psychosis, that is sort of part of the trajectory of untreated PTSD. They were labeled schizophrenic and put on Thorazine and put in the locked wards because people thought that flashbacks were psychosis. Of course, we understand now that that's not the case. We also know, again, as we're learning this week, that psychotic symptoms can be part of a lot of different things. Not getting any sleep for too long can cause somebody to hallucinate. Medical conditions, medications, if you have a bad reaction to a medication. I mean, there's a whole lot of things that can lead to that. But I think our tendency is to jump to schizophrenia until we understand more about how all of these things kind of fit together. And the sort of spectrum, not just the schizophrenia spectrum, but the spectrum of symptoms, from mood symptoms to psychotic symptoms to anxiety symptoms, how we understand how they kind of can interact with each other. So all that to say, I really enjoyed reading about your differential diagnosis thoughts and how you compared it to other disorders. Always go back to the DSM. If you're not sure when you're trying to diagnose somebody and you're not clear, is this a mood disorder? Is this bipolar disorder? Is this major depression with psychosis? Is this schizophrenia? Is this schizoaffective disorder? Is this brief, or is this sticking around for a while? Has there been drug use in the mix? All of these questions you're asking are great. You go back to the criteria in the DSM and you go point by point by point. And very often you'll think, yeah, I know, I'm really confident that it's this disorder, and then you start reading through the criteria again and you go, oh, yeah, no, we gotta look somewhere else. Or yes, for sure, this really is, I feel, confident. So, great job. Y'all are doing a really good job. This week we'll be talking about major depression, and then next week into bipolar disorder. Major depression it's very common. It's one of our most commonly diagnosed mental health disorders, and really health disorders in general, because it is a health issue. It's not just a mental health issue. So I hope that you find the information useful and helpful. There are so many directions that we could go. I just want to dive deep into, treatment for major depression, but that's not what we're here to learn in this class. So we're going to have some discussion around that, if that's helpful to you all. But this is more about, understanding the difference between the different depressive disorders, with the main focus being on major depression. And then some comparison to anxiety disorders. There is some discussion of what depression looks like in children. And I want to mention, you'll come across this in the recorded lectures, but in the DSM-5, there were still sort of qualifiers that differentiated depression from grief. And new to the 5TR is the prolonged grief disorder. So make sure to go back and take a look at that. I included it in the reading. You don't need to dive deeply into it, but I want you to at least read the criteria so you understand the difference between major depression. Major depression, if somebody meets criteria for major depression or PTSD, it is a rule out for prolonged grief disorder, but it is new. We may look at it again when we get to that section in the DSM, but I want to make sure that you're able to differentiate between the two. And the basics of prolonged grief disorder, again, there's a list of, I think, 6 or 7 criteria, and you have to meet a certain number of them. But it's related to the loss of a person, although in the mini lectures, Dr. Mabry references other kinds of losses. So I really wonder if this is one of those situations where we will recognize over time that grief is not just about a loss of a person, but other things can lead to this kind of symptomology. But the prolonged grief disorder discusses a loss, the death of somebody close to you that was 12 months or more ago, and that these symptoms, they're very similar to depressive type symptoms, but with a real focus on having a hard time getting away from, or alternatively really avoiding cues reminding you of this person that you've lost. For children, it's 6 months. For adults, it's 12 months. So take a look at that. Make sure that you understand the difference between that and major depression. I hope that's helpful. The other thing I wanted to mention, this is ECT or shock therapy is mentioned in the second mini lecture, but I've added a link from the Mayo Clinic. There's lots of different places you can go for this information, but Mayo Clinic tends to be pretty reputable and thorough. In addition to ECT, a lot of treatments are being developed have been developed and continue to be refined for what we call treatment-resistant depression. And that is essentially major depression that just is not budging from traditional treatment approaches. And it doesn't take much. I think it's like having tried 2 pharmaceuticals and not seeing results to potentially qualify as treatment-resistant depression. So in addition to ECT, TMS, which is transcranial magnetic stimulation, I think. I'm sorry if I got those letters a little bit wrong, but TMS is magnets, essentially. And ketamine is the other. So those 3, ECT, TMS, and ketamine, are 3 of the popular and kind of emerging treatments for treatment-resistant depression. Of course, you would try less intrusive approaches before you moved into those, because they are more intrusive. So I included a link. It'll give you a basic description. It's not super long, but I wanted to kind of have that information out there that was helpful to you, because I think depression can be one of those things that it can feel heavy as a therapist treating people with depression, or working with clients who have depression that doesn't want to budge, that's been with them for years, and you can get pulled into that. I'm not saying anybody's trying to pull you into it. I'm saying that your empathy can really lead to discouragement when you're just seeing people sad for a long time. So just to know that there are lots of efforts out there and research out there, continuing to develop treatments that are helpful. So that's it for now. You all have your exam that is due on Wednesday, I think is the 12th, but certainly the 12th, might be Thursday, but it is the 12th, whichever day that is. I can't see my calendar right this second. Wednesday at midnight is when the exam is due. So please be sure to get it in. That is a 2-day extension. For those of you who are tempted to ask for an additional extension, know that you already have one. And so please try to do your best to get it in by then. And then you'll have another discussion prompt for next week. And hopefully that won't be too overwhelming. Again, you had a solid week, or almost a week to access your exam and get it in. So let me know if you have questions, and I will probably change the exam the next time to, not just a Word document. It'll be a similar structure. But this should give you an idea of what to expect for future exams. So have a fantastic week. Let me know if you have questions, and I will see you soon.